we will proceed to the next presentation, again given by a Dr. Shakra.
This is my presentation.
It
Yeah,
is
okay.
your, and this is a symposium.
Symposium. Yes.
Yes, sir. Sponsored by Lily, and it will be today about emgality and migraine prevention. Sorry.
Thank you, Ahmed, again. So this is a symposium sponsored by Eli Lilly about emgality in migraine prevention. As you know, emgality is galcanezumab, which is a new type of medication of anti-CGRP injection that are given monthly as preventive therapy for migraine headache, episodic migraine, and chronic migraine. So this will be a little bit going through introductions, and I'm presenting the cases with some review of the literature. The first case is in fact for female 29-year-old lady who works as a front desk customer service in some of these companies in Abu Dhabi. She is also at the same time university student. She's married, having one kid. She does have comorbidity of asthma, but not in regular inhaler therapy or any regular therapy. She has positive history of migraine in her mother, in history that she had diagnosis since 2008. She used to have 1 or 2 attacks per month, that not more than 2 migraine days in a month, which usually was manageable by simple analgesics. Now, when she joined her duties or job in 2017 with this customer service front desk, very busy, very noisy area, stressful situations, she started worsening her migraine become even more frequent, more severe, more prolonged, not responding to the usual treatment that she used to take. She was seen at that time by a private general physician and advised for triptans. I think she was given at that time sumatriptan. Anyhow, over the years, still not seen in our clinic. In 2017, 2018, headache was worsening. Frequency was about twice a week. Attacks may persist for a couple of days or 3 days. So first time in 2018, she was seen by a private colleague in a private neurologist, and was prescribed amitriptyline. Unfortunately, she did not tolerate it because of morning sleepiness that interact with her duties and study. So he advised to go for Botox therapy. Again, she was unfortunate in the first session. The Botox was complicated by ptosis. She started getting fear, and she did not continue on Botox, although she got some improvement with even the first session of Botox. So in 2018, she kept on very low dose of amitriptyline that was verbally not even effective at all. So first time she came to our clinic was in January 2019. At that time, the headache was, according to her diary, she carries the diary all the time in her mobile, was between 8 and 12 every migraine days every month. She has very poor response to somatriptan at that time. So we suggested the new modality of treatment that was available at that time, anti-CGRP. However, she was hesitant. This medication is new. We don't know about this medication, something like this. Again, she was planning even to go outside the country and continue her master degree. So she did not accept to take this medication. So finally, we start getting her low dose of topiramate. We increase it a little bit. Unfortunately, again, when she became 50-50, she stopped it because of cognitive impairment. By 2019, just prior to her travel outside, she was having 11 days of migraine, and she used to take 1, 2, or 3 days every month for sick leave, usually because of headaches. Between April and October 19, she was in education mission outside the country in England. She was seen there by a private neurologist. Again, he advised for anti-CGRP. Unfortunately, due to insurance issues, and that medication was not approved in UK, so she did not receive the medication. But she came with more probably open now to take this medication when she joined again in November 2019. So as you see, this is complex case of high frequency episodic migraine with very poor tolerance tolerance for the usual traditional preventive therapies. Again, it's affecting her badly in her life and in her job, in her responsibilities. So we discussed with her when she again came about how to manage the migraine, how to even manage to control the triggering factors, how to improve the impact of this migraine on her job and her duty in her family, everything. So we start her by the end by Emgality. So she started the loading dose of 240, that 2 injections in December 2019, and she was initiated in England on Zomig, which was doing better than somatropitan, so we asked her to continue on Zomig as rescue therapy on BRN. So first month there was very good, in fact, improvement in the headache frequency and severity. The reduction of headache was almost 50% of the days. Remember, she was 11 days, now it's 6 days, almost like 45% reduction. She less are using Zomig as rescue therapy, and there was no appreciated adverse event, even no injection site reaction. Second month and third month also improvement was continue more and more prominent. By the end of third month was only 2 migraine headaches, very good response to Benadryl and Brufen, and now she's out of topiramate and amitriptyline, no sick leaves, no side effects. I saw her in November 3 weeks ago. She was having even 1 day or 2 days headache every other month. She's not on any triptan, hardly she's using any rescue therapy. No reported adverse event or undesirable side effect, no sick leaves for the past 6 months since she started the treatment. This is very good. Yeah. This is extremely very good for her. No way, at this point, in fact, I discussed even to stop the medication, but she refused as she is appointed recently to be a manager, and she thinks that the new job is very stressful and she needs some good medication not to be again in same situation like previously. So this is in fact a very good example for what we know or what we saw before in pivotal studies, the Evolve 1 and Evolve 2, which are in fact very identical studies. One of them was in North America, the second one was in the rest of the world. And as you can see, the reduction start and the improvement start extremely early, as with first months here. As you can see, either in Evolve 1 or Evolve 2, there is significant reduction in migraine headache days starting from first month. And there's some, if you, there's other studies that looked even by weeks, it's starting from the first week. This was our case example, in fact, very good example for this study. Again, we know that the Emgality is the only probably only medication, and it's a class that is having a pre-specified endpoint when it comes to higher more than 50% reduction in migraine headache days, more than 75 and even 100 or headache free. And our case, as you can see, can be considered probably at 75, more than 75, up even to 100. In fact, in a few months, she was headache free. So this is a very good example. And as you can see here, there are almost 40% of patients are in fact having 75 reduction in headache days. And we have even good percentage, up to 16%, that are becoming headache free after using Emgality. This is MIDAS, which is in fact a measurement. In fact, we don't use, unfortunately, in our clinics, but it's very easy. It can be done by a nurse or by patient. It's a questionnaire from 5 items. It's very easy to be done. It's a reflection of the impact of headache over the or impact of the over the quality of life. And as you can see, there is in fact 80% of patients get more than 50% reduction on this scoring of MIDAS scoring system of quality of life, which is a significant improvement, in fact, especially when comparing with the placebo or other even type of medications. So going to my second case, is this a male, 36-year-old. He's manager of a big company in this country. He's married with 6 kids. He has a history, remote history of depression. He has family history of migraine in mother and his older son. His history started in 2003 when he used to get attacks of migraine, 2 to 3 attacks, almost 2 days of them at least are migraine headaches. The headache usually was due either to emotional stress, sleeping disturbances, noisy environment, perfume, sunlight exposure, and job stresses. Usually, headaches at that time was relieved by over-the-counter medication because considered and very much manageable. In 2013, he was appointed to his job, start getting symptoms of depression, worsening of the headache. Headache becomes like once to twice a week, more severe, more prolonged, more resistant to treatment. Again, he was initiated by triptan. He in between 2013-16 had it become even worse and almost become daily with daily using of analgesics. He was initiated by a colleague in private sector on propranolol and amitriptyline, no improvement. 3 sessions of Botox, again mild improvement. Continue after the in 2018 on amitriptyline and propranolol. He at that time he was following our clinic, and we lost him in fact in 2018 due to lack of efficacy of the medication, and however he continued with psychiatry due to depression. Again, he shows up in our clinic in June 2019 after getting information by media and by his psychiatrist about the new modality of medications. At that time in June 2019, he was having almost 20 days of headache and migraine days of headache, while in the rest of the day of the months he was even having headache, but it's type of dull tolerable headache. Daily using of painkiller, used especially ibuprofen and diclofenac with Panadol migraine he used to take, not the usual, but without it was useless. Was not on any preventive therapy. He stopped all medication. However, at that time he was in quetiapine and sertraline by his psychiatrist. So it was very complex case of a chronic migraine. Chronic migraine, consider when we have 15 days of headaches every month, at least 8 of them are of migraine characteristics. So this type of, we are having migraine, we have overuse headache. Again, if you go and dig in the specification of headache, you can find even the migraine overuse headache. He has background of depression. He has severe impact on his life, family life, and even job duties due to stresses and depression. So when he arrived in clinic, again, we followed the usual management plan. We discussed migraine, triggers, impact of this, migraine and depression, how to manage both of them. And we start educating about the new type of medication. So patient was in June, it was started 2019 on Emgality, again, loading dose with 2 injections, 240 milligram. We asked him even to start naproxen regularly for 500 BID for 14 days in order to get rid of the medication overuse or medication over-the-counter abuse of the medication. We asked him to continue now quetiapine and sertraline and to follow recommendations of his psychiatrist. So he started doing very well, in fact, from the first months of injections. Again, he got first months after injection, almost 10 days of headache. He used only 8 tablets of elytriptan as painkiller. He has to use this one. We did not allow to take more than 8, in fact, tablets, and we asked him just to use in case of recurrent headache to use naproxen as on regular basis. There was no adverse event, and so in the second and third months increased again. The attacks are frequency and severity improved remarkably. No sick leaves at all, even in the third month. In second month, there was 2 days sick leave. He hardly, in fact, has to ask for sick leave, although he was having severe type of migraine. Improvement continue after 6 months. Now he having 1 headache probably every month, 1 migraine headache resolved by simple analgesic. MIDAS is very good. The score is probably 1 or less for no more disability. He is better. He's continued to receive Emgality regularly, monthly, without stop. Even during the pandemic, he used to come and collect his medications. There was no desirable or unwanted effect. His depression was improved. Currently, he's on low dose Onzaloft, not anymore on Seroquel. He used to say that my Emgality, in fact, changed his life and saved his life. This is his own word. So again, this is a reflection for what we know from a Reagan study, which looked at the chronic migraine. We know that Evolve 1, Evolve 2 looked at the episodic migraine. Reagan is looked at the chronic migraine. And again, you see again significant, more than 50% of patients get improvement in 50% of migraine headaches, as you can see here. Again, when it comes to migraine, we know that it's not only days of migraine, it is quality of life, it is commitment to the medication, it is adherence, it is adverse event, all this stuff. So what we know, this type of medications that, in fact, when it comes to the completing the study of Emgality, we know that due to remarkable safety and tolerability, majority of patients, in fact, completed these studies in episodic migraine and in a chronic migraine, more than almost 90 and 95%. There was 2%, in fact, less than 2%, in fact, withdrawal due to probably adverse reactions due to injections. Less than 0.5, in fact, even get the withdrawal of the studies or get the injection site reactions. And we know that the commitment of adherence is more than 80% among this population of the patient. We know that for traditional preventive therapy, including amitriptyline, propranolol, and even topiramate or other mid-type of dipakine or other type of medication, hardly to find more than 20% are adherent to this medication by 6 months or by a year. So a huge withdrawal when it compared with comparing the anti-CGRP with all the traditional type of medication for preventions. We start, in fact, usually for Emgality with the loading dose in order to get this here, as you can see, the, in fact, it's steady, stable.
Dr. Chadha?
This is the last slide.
Okay, 5 minutes remaining.
Okay, as you can see. Now, in case if you start with first injection, you will get slowly over months, but if you get first dose as high dose, you will get as, in fact, steady state or concentration of the medication immediately and very soon, which is advantages. This is the medication that are given injection belt, which is very easy. Usually our nurse is giving the one of them and patient himself that take the other one, and then they use one injection every month. So by conclusion of Emgality, this is the only agent that has a pre-specified response rate of 50%, 75%, and 100%. In fact, significantly, we have higher response rate observed in Emgality than placebo when it comes to episodic migraine and the chronic migraine. As we saw, it is very early, start from even first week, not even from first month. There was even a slide, I think it was hidden here, that shows, in fact, even the improvement, it shows up from first week. And again, there's a remarkable improvement in quality of life and functionality, either in episodic and the chronic migraine, as it was even clarified or illustrated by improvement and MIDA scoring, remarkably improvement more than 50% as early even from first few injections. It is very tolerable and has very favorable adverse event profile. Thank you very much.
Thank you again, Dr. Shakra, for another very nice lecture.
Thank you.
We do have a question from Hamza Baravi. How can we differentiate between painkiller headaches and chronic tension type headaches?
Tension type headache. Okay, tension type, it has in fact two types. In fact, it is usually featureless headache. Okay, the tension type, usually the episodic, it's several days, it's featureless, doesn't have any impact on life, it doesn't interact with daily activities of living. It's like heaviness, patients feel that they have heaviness in their head or pressure inside their head. They don't affect their daily activities of living. There is no throbbing, there is no phonophobia, nothing. While medication, in fact, of medication overuse headache is appreciated, especially in patients with migraine when they are using a type of analgesics that are usually short acting, like acetaminophen or NSAIDs. in order to control the pain. With the frequency of headache, they get improvement in headache. However, over time, more than 3 months, they start getting between attacks a type of headache that is different from migraine, but again, it is irritating, and again, it is interacting with daily activities. So they don't have any days without headache. In days they get the medication, they get little improvement in migraine, but in between migraine and migraine, they get this type of headache that they are when they are not using these over-the-counter medications.
Thank you very much. We have a question from Esma. Any significant difference between Emgality and Aimovig? Aimovig, as you know, is the other
I know.
CGRP.
I think
No, for the audience, I'm sorry. Regarding response and side effects.
I think we responded there. There is no head-to-head, in fact, comparison between them. And currently, we cannot give any judgment about it due to differences in number of patients who are taking this medication or other medication. When it comes to mechanism of action, in fact, there is differences. As you know, one of them is in fact targeting the ligand itself, while Aimovig is targeting the receptor of CGRP itself. Usually we start Emgality with loading dose, but we don't start, in fact, Aimovig with loading dose. We can increase the dose after 3 or 4 months if there is a minimal response. Otherwise, I think side effect profile is almost all of them for all this category of the medication is almost the same, and this is what I can say.
Very similar. That's pretty much very similar side effects between both drugs. Sophia had asked a question, do you think the treatment of patients with migraine would need collaboration between a neurologist and a psychiatrist? And do you know of any new antidepressant that's effective in treatment of migraines?
Yes, of course. Certainly, when it comes to that, the migraine becomes chronic and impacting the quality of life, in fact, impacting even the family relationships or duty responsibility. At some point, we, in fact, still need the help of psychologists. Now, in some occasion, with the chronic migraine, we can appreciate, in fact, depression syndrome associated with this, so we can find all the parameters of depression, and we start usually treating these patients either before anti-CGRP even, and now even we can start treating them either with amitriptyline or duloxetine. So this type of medication we can use. In fact, Effexor, I told you, we have patient is in Effexor who is doing very well, in fact, in Effexor for migraine and depression. So again, depression is very common among any chronic disease, including chronic migraine.
Thank you. Do you dose it differently if someone has acute kidney injury or chronic kidney disease for Emgality?
No, there is no adjustment for hepatic dysfunction or liver dysfunction or renal dysfunction.
Well, thank you very much, Dr. Shakra. Just for purpose of times, there are a lot of questions. Unfortunately, we are not able to get through all the questions, just for the sake of time and keeping the speakers coming, and so no one misses their lecture. And so thank you very much. And it's always nice to see you virtually.
Thank you very much. Only virtually?
Well, I'd like to see you in person eventually when this COVID thing is better, but until then, virtual is going to have to do.
Thank you very much, Ahmed.
Thank you.
Bye.
مع السلامة.